Good morning, everyone. We had a little bit of technical difficulties, but we appear to be ready to roll. Go ahead and get us started. To all who are new here, welcome to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are updating our upcoming schedule frequently, so check back often. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz evaluation and assessment. You'll have up to 72 hours to complete the quiz and the evaluation. This email will come from customer care at gotowebinar.com. Please ensure that this is done timely in order to receive your statement of credit. If you don't receive the follow-up email or have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion. If you cannot see the PowerPoint slides, and you're accessing the webinar from your mobile phone, ensure that you've got your swiping the screen to the left or the right so that the slides can become visible. Our speaker this morning is Dr. Caitlin Mooney, who's a pediatric sports medicine physician. She did her undergraduate at Notre Dame, her medical school at Vanderbilt, residency at MUSC in South Carolina, fellowship at Case Western, and now works at UT Health San Antonio. She serves as the vice chair of the communications committee for AMSSM, and she's the chair of the subcommittee of social media. She's presenting today on cycling medicine. So you can see your screen. If you want to go into a presenter view, yep, perfect.
Okay, perfect. And you can't see the panel on the side, can you? Like the webinar panel? Okay.
No.
Great. Let me move that real quick though, so it's not in my way. Okay. So my name is Caitlin Mooney. I'm going to be doing an introduction to cycling medicine. So this is made to be kind of like a primer, but get your feet wet into cycling medicine because it's something a lot of people aren't exposed to. So my objectives are to identify the key components of bike fit, apply basic bike fit knowledge to address overuse injuries, and to identify that by the end of this that you can identify some common acute injuries in cycling as well. I have no conflicts of interest. So cycling is an increasingly popular sport, even more so after this pandemic. During this pandemic, as a lot of people are buying bikes and riding them, but it is known to be a lifetime sport with multiple fitness benefits, including cardiovascular benefits. People use it to lose weight. It's easy on the joints as it's not full weight bearing like other activities such as running. It's a green mode of transportation. And as I said, it's more popular. There are many different types of cycling. We have road cycling, which is a form of racing or sport activity. There's different types of road racing as well, including road race or circuit races. There's cyclocross, which is kind of a mix between road and mountain biking, where it looks more like a road bike, but it is on grass or dirt or gravel, and people have to run and jump over things as well, or if they can get their bike to jump over it, they can do that. Track mountain biking, which also has many different disciplines. Triathlon or multi-sport, so the most common being running, biking, and swimming, but there are other types as well. Commuter riding, recreational trail or touring, BMX, and then this was a little more popular a couple years ago, but fixed gear alley cat urban riding, which they had their own little alley cat races as well. Those still do go on, but they're a little less popular. To cycle, you need some equipment. So you need the bike, everything you need to keep a well-maintained bike. So pressure, like a pump, oil, those sorts of things. A good pair of shorts can be very helpful. So padded shorts really help keep the sit bones more comfortable. Shoes, well, not everyone needs special shoes for cycling. A lot of the more serious cyclists do have a clipless pedal system, so that there is a binding that holds the shoe tight to the pedal and improves efficiency. Helmets are very important to prevent skull fractures, and I think sunglasses are equally as important, or regular glasses, to prevent anything from flying in your eye. And then gloves are very helpful as well. There are two main types of cycling injuries. One would be acute injuries, which are sustained by a fall or collision, most common being clavicle fractures, but any sort of arm injury is also common, as well as other blunt trauma injuries. 2/3 of acute injuries are going to be upper extremity. Concussions are also common. Chronic overuse injuries are also common, as it is an endurance sport. About 2/3 of these are going to be lower extremity, but they can include any other body part. So to think about overuse injuries, I always like to go back to overuse injury models. So a successful treatment or prevention of overuse injury is really based on identifying any of the modifiable risk factors and trying to change those so that the athlete doesn't come back to your office with another overuse injury. So we have intrinsic factors as well as extrinsic factors. So intrinsic being intrinsic to the athlete themselves, and extrinsic being something environmental or a factor based on the sport. So some intrinsic factors, some of these are changeable, some of them are not. So age, the gender, the maturation of the athlete, weight, their health and fitness level, whether they previously had an injury, or even psychological factors like their drive, their anxiety, sleep, all those sorts of things all play into your risk for overuse injuries. Extrinsic factors are going to be what sport you do. Are you doing mountain biking? Are you doing road biking? Are you riding your Peloton? Those are all going to impact what sorts of injuries you can have, but all of them do have a risk of injury. What equipment you're using. Is it a well-maintained bike? Is it a well-fitting bike? And also the environment that you're riding in. One thing to think about when you think about cycling is that, especially for road bikers who are clipped in, so where they're attached to the pedal, if they're cycling at 90 revolutions per minute, that is 5,400 revolutions an hour. If they're not moving on that saddle, almost all of their pedal strokes are identical. So more than a lot of endurance sports, that's a very, very repetitive motion. So a minor misfit in your bike fit can really lead to a lot of pain or injury. Some basic bike anatomy. Biggest things to think about are our contact points with the bike. So that's going to be our hands to our handlebars, our pelvis to the saddle, and our feet on the pedals. So our goal for a good bike fit would be to have a comfortable, safe, and efficient rider. So some of the bike fit components are really to be the most efficient, and then some are for comfort. A well-fit bike also prevents acute and overuse injuries, and it's really based on these 5 contact points. And there's no exact right position. It's really a window or a bullseye, and there's always room to move. If something's bothering someone, if they go in for a professional bike fit, they should always be coming back if something's not feeling correct. So there's a medical guide for cyclists. That was a book made by Andy Pruitt. The idea is that the bike fit is really a marriage between the rider and the bike. You should always make the bike fit your own body, not your body fit the bike. So it's important that people don't buy too big a bike, too small of a bike, and then try to make themselves fit it. That's not going to be a very comfortable way to ride. A dynamic bike fit is better than a static bike fit. So static bike fit would be you sit in one position, they're doing some measurements, and then going from there. Dynamic bike fit, people move while they're riding. So even just doing a warm up, you'll probably be sitting in a different position than you would if you just got on the bike. And then they can also measure things like power and other things while you're actually riding. Those do tend to be more expensive though. Cycling is a sport of repetition, that there's always a window of fit, and then mountain bikes are the exception. People are moving around a lot more on a mountain bike, so there's not really as strict rules. And when people go downhill, usually they want their saddle lower. There's now drop posts, but that almost all these rules do apply a little bit to mountain biking, but there is a little bit more of a window of what's acceptable there, and they're just moving more. So the bike fit is not quite as important. It's not quite as repetitive. So here's an example of a bike fit where they're doing some measurements, and then up above is kind of a video bike fit. They can do all sorts of dynamic things based on video or sensors now. And there's many different kits available at different bike shops, or even some sports medicine groups do have bike fit capabilities. A poor bike fit not only causes problems at those particular contact points, but can also cause problems elsewhere, like the hip, the knee, the back. So it's really important to be cognizant of a bike fit. It's also important to know there's different goals of bike fit. So you might have a medical goal. Someone with a hip replacement probably cares more about being able to bike comfortably with their hip replacement than a professional cyclist who cares a lot more about performance. And bike fit is separate than bike sizing. So if you go in and you get size for bike, they're really just picking the frame size by doing some common measurements and maybe using a grid. So that's not quite the same. So what's our goal for a good bike fit? This is from Netter Sports Medicine, but kind of like a good baseline goal. You're going to have your arms slightly bent in flexion, your hands on the hoods of the bike, some degree of a comfortable lumbar flexion, a saddle height where at the bottom, if your foot's at the 6 o'clock position, you're going to have 35 degrees of bend. And then if your foot's at the 3 o'clock position, as in the picture, your knee should be over the spindle and over the metatarsal head. Sorry, my dogs are barking. And then also important to know that correct posture is really important. If the first guy to the left is kind of not in a good position, has really poor core strength, and so his sit bones are in the wrong position, he's putting a lot of pressure on his arms, and that's going to be a very uncomfortable position. So for frame size, the most important thing to think about for this is that you want to ensure that there's enough standover height so that if you make a sudden dismount, you're not going to get a peroneal injury. And fit guides for the bike brand itself are a good start for that. And there's a variety of methods you can use to kind of get at least in the ballpark. Our first area of our bike and our body contact I'm going to go over is our saddle. So if you look to the right, different positions of leaning forward have different areas that your pelvis actually contacts the saddle. So these deep leans of the professional cyclist are going to be right on that pubic bone, whereas more upright recreational rider is going to be farther back on the ischial tuberosity. The professional cyclist is going to have a narrower saddle probably that they're going to be comfortable with compared to a recreational rider. There are some incidences of contact. This is probably the most complained about contact area problem is going to be peroneal numbness, irritation, saddle sores. There is an idea that there might be a relationship with erectile dysfunction, but that has not been actually proven to be the case. But there is some idea that maybe there's decreased perfusion that would be the cause of it, and it could be that some people have poorly fitting saddles. That actually isn't well elucidated. There's probably needs to be more studies on that. Women can have a urethritis where they can have pain with peeing, after riding. Usually that's caused by too much pressure on the perineal area as well. You really want the sit bones to be above that outer area, that optimal area of the saddle, not on the edges. The second thing is saddle position. Hold on 1 second. So our saddle height, we want to have 25 to 35 degrees of bend at that 6 o'clock position, as I discussed earlier, and is approximately depicted to the left. And then a good starting point for saddle setback, or how forward or back it is that you want the knee over the pedal axle at the 3 o'clock position. In general, a tilt's not necessary and means that your fit's probably not good if you have to tilt it forward or backward. For mountain biking, as you can see on this rider, I think it's a girl, her butt is all the way behind the saddle. So they really want a lower saddle if they're going over obstacles, because they want to be able to clear that saddle. So some saddle position misfits, that I think this is the most common problem, is too low of a saddle causes excessive bend at the top and increasing shearing forces on the patellofemoral joint. When I go to bike trails, I always see too low saddles. Too high, poor power and excessive pressure on the perineum. It also can strain the hamstring. I don't usually see that one. And then tilted downward. If the saddle's tilted down, you're putting your weight more forward, so you're going to have a lot of wrist and hand pain. That also pushes all your weight forward so that you're accidentally pushing on your handlebars, and that you're not going to be able to steer very well. To choose a saddle, all companies have nice little saddle measurement tools, and this is this one from Specialized, where you sit on it, it makes a little indentation, and then you can measure what your sit bone width is. The biggest thing is that you really want the sit bones, or whatever part of the pelvis that you're balancing on, needs to be supported by your saddle. So it has to be wide enough, flat enough, firm enough. A cutout can decrease the pressure in that center area. Different shaped saddles sometimes help people who are having problems with saddle fit. But one of the things that people like to do is get a more padded saddle, but that actually puts a little bit more pressure on the perineum. You really want support. So generally padded saddles aren't your friend, although for gravel or mountain biking, you do want a little bit more padded of a saddle, just because there is a little bit more impact there. And then women tend to need wider saddles because they do have wider hip bones. To prevent saddle sores, one of the biggest things is having a padded liner of a short. They should be changed frequently, not worn while they're wet. Avoid old ones that are showing wear. Gradually increasing mileage can also decrease risk of saddle sores, making sure everything fits well, and moving around, so not sitting in the same position on the saddle the whole time. Creams and ointments are also very helpful to decrease friction. If you actually get one, you should probably modify training. You can try to pad with moleskin or bandages, put on a second pair of shorts, or change positions more frequently. My second area of contact is going to be our hands, the handlebars. This is also a very common problem. Ulnar neuropathy, or where the ulnar nerve gets pinched, where you're putting your pressure on your hand at the 5th and 4th finger, is pretty common. Weakness is actually a late finding and not as common as just numbness or pain. And while some people will get this regardless, just because of the length of time or the terrain they're riding on, frequent changing positions or not holding as tight can be helpful, or changing gloves or wearing gloves if you hadn't previously been doing. The proper handlebar position really is based on the type of riding you're doing. So to the right, more professional riders are going to be very, very far down, very long reach with a lower torso, with a more aggressive torso angle. Recreational riders will probably ride at that fourth one over to the left, where they are in a more comfortable position, not as aggressive, not as aerodynamic. A good starting point is tip of elbow at the tip of the now well-positioned saddle. So you have to do the saddle first, and then extending to the toward the handlebar, and within an inch of the middle finger. Then you can always adjust from there. And then all the hood and the levers can be moved along that handlebar as well. You will see like the more aggressive riders, competitive riders are going to have their seat higher than their handlebars. Our third cycling contact area is going to be our shoe and pedal interface. A lot of cyclists do also complain of burning feet, numbness, or pain, sometimes called a hot foot. That can be any number of conditions. Metatarsalgia, or pain of the metatarsals, plantar neuropathy, or Norton's neuromas are also common. You can treat these as you would any sort of athlete that has those problems, but other specific bike-related things you can do is try to widen the toe box, widen the cleat so there's less pressure in one spot, a stiffer shoe, or a metatarsal bump or pad that spreads out the pressure. The cleat and the shoe interface is really the most complicated because you can move the cleat in many different ways. I'm not going to go into this too much, but you can move it forward, backwards, medial, lateral. Some people actually have a little bit of an angular deformity, so you can correct that with wedges, or if leg length discrepancy, you can put a lift on one side too. That's getting a little bit more on the complicated end of the bike fit. And then all those cleats can have some degree of built-in rotation, so a little bit of floating back and forth to the sides. Most have only 20-30 degrees. There are some free-floating brands, though, that really you can go as far as your leg can really go. And then in these slides, I have some starting points for where you would want to set somebody up. Really aligning the knee over the toes is where you want to start, and kind of troubleshoot from there if someone's having any issues. And then if you look at the knee being not over the toes, then you want to change either medial or lateral. I'm not going to go into wedges or any of those other things. So here's our first medical overuse problem that we can address by bike fit. I talked about this a little bit earlier, but the most common thing I hear people complaining about is really knee pain. And this is really common in other athletes as well. You can include the typical treatments of all these things, but then also think about some recommendations you can give for bike fit if someone complains about these problems. So anterior knee pain, incredibly common in all athletes, ranges from patellotendinitis to patellofemoral pain. You can use your typical treatment plus check the bike fit. This is most commonly the seat's too low, and then in the motion, it's causing excessive loading to the anterior knee, especially with hills and high gears. I also find a lot of people like to kind of grind, be in a really high gear, low cadence. If they are kind of more spinning, high cadence, lower gear, especially getting climbing out of the saddle, they're not going to have as much anterior knee pain. PES bursitis. So PES anserine bursitis is where is inflammation, irritation at the PES bursa, where the hamstring tendons come and attach. This can be found in cyclists if they're overloading those hamstrings. Common also in fixed gear cycling, which I'm not sure if you remember the trend, but that's where the cyclists, whenever they're pedal, they're actually moving, so there's no there's no, you can't like pedal backwards because it's just a fixed gear. And a lot of those cyclists also don't take the brakes off their bikes, so they brake purely by pushing backwards on their pedals, and that can cause hamstring strain as well. Alignment problems can cause that, as well as clipping in and out. When you clip out or remove your bike or your foot from the pedal, that puts stress on the hamstring as well. So you can decrease the tension on the clipless pedal system if that's a problem on your leg that you're most commonly taking out. Medial knee pain, also common, although not as common as probably the first two. This is usually a saddle that's too low or excessive float in the pedals, and that's not a common thing that I see. I don't usually have people complaining of this with cycling, but it can be treated the normal ways and pretty similar to anterior knee pain. IT band pain, also not quite as common in cyclists as probably in runners, but that can mean that your stance is too narrow on those pedals, so you can move them, or pedals without enough float. Posterior knee pain, again, I don't think this is that common, but I wanted to include it just in case anyone was troubleshooting these problems. And you can change the float or lower the seat if this becomes a problem. I wanted to get to some of the more common ones. Back pain is also incredibly common with the anterior knee pain. Some cyclists really like to put their position into a more aggressive race position, but they might not have the flexibility or the core strength to be in that position. So that's one common cause of that, as well as just all common causes of back pain can also happen to cyclists. And then also other things like leg length inequality or, like I said, too much reach are very common. So treating back pain, same way as you treat a lot of other overuse injuries. With therapy, you want to do a strengthening program, decrease the reach, move around on the bike more, and then probably build your mouths a little more conservatively. Scapular neck pain is pretty similar to back pain, caused by excessive reach. So coming back up to more upright posture can be helpful. Achilles tendonitis, I don't see this a lot, although I do have a couple people in my spin class who complain of that. So that can be a cleat in the wrong position, pedaling on the toes. I also think sometimes in spin class, they emphasize kind of driving down the ankle in the downstroke and pulling up on the backstroke. And I think that puts a little more stress in the Achilles. So kind of thinking more of trying to get bubble gum off the bottom of your shoe instead of pulling up when on that backstroke can be helpful for that. And always making sure your fit's correct. Tib anterior tendonitis, also probably not super common, but a lot of times that's going to be excessive strain on that upstroke if the foot is in that dorsiflex position. So kind of avoiding forceful pulling up of the foot can be helpful. Or if they're reaching at that very bottom part of the stroke, that can cause that, so lowering the saddle can be helpful. Here's just some general quick shooting guides of common problems and ways to start thinking about moving things around, because I know there's so many moving parts on bike fit. That's why I wanted to target kind of the more common ones, put the less common ones in here, but also just give you tools if you ever have someone complain of something, what you can think about telling them. I wanted to touch a little bit on one condition that really is almost only seen in cyclists, which is iliac artery abnormality. So if you look at the picture, our iliac artery can become kind of impinged or kinked when we're in the superflex position. And there's actually been up to 20% shown that up to 20% of elite cyclists can have kinking, lengthening, or an endofibrosis of most commonly the internal iliac artery, but it can also occur in the common and external. They complain of kind of this dead leg, lack of power, and thigh pain, and there really needs to be identification. Like, if you're not looking for this, you won't find it. And so different imaging techniques and also the ankle brachial index can be helpful to diagnose this, but really a high index of suspicion and probably talking to experts or radiologists on what's the best way to diagnose this if you were suspicious of this problem. It's a frustrating problem because it really needs to be identified early, or sometimes surgical revascularization is more complicated because it can become calcified. But I wanted to include this because this is really only seen in cyclists and usually with more time in the saddle. Moving on to more common traumatic injuries, which are mostly upper extremity. Traumatic injuries are very common. So a survey of a Masters Road Club showed that really quite a number of them had an ER visit, 79 out of 81. Their collision with cars are thankfully not super common, but do occur. So that can result in admission to the hospital, ICU visits. Fractures are very common. 54% of these master cyclists had a fracture. 90% had a road rash. 45% reported having a head injury. And also important that master cyclists, if they've had a really long history of cycling with non-impact training, they're at increased risk of osteopenia and osteoporosis. Sorry, I got frozen. There we go. Some people say you're not a cyclist until you broke your clavicle. I've been cycling for over 13 years and, knock on wood, thankfully have not broken my clavicle. But this is really the most common acute injury. Survey of 140 professional amateur road cyclists showed that the risk of fracture really increased with time on the bike and years as a cyclist. So if you look at cyclists who spent more than 10 hours of weekly training, they really have a higher rate of clavicle fractures than these cyclists who had less. And then also over 20% of cyclists who've been cycling for greater than 10 years have had clavicle fractures. So one of those things that just with time, you increase your risk. And I'm not going to go into the management of clavicle fractures, but I wanted to include a link of a great summary of the current evidence for how to manage clavicle fractures by one of the orthopedic surgeons on Twitter who has some great sports medicine information on his website if you want to take a look at that. Road rash is very common. Ways to prevent it is just having better bike handling and avoiding risk, but most people who have cycled for a while have probably experienced road rash. It varies in degrees based on how much skin disruption there is. You generally want to clean the area with warm soapy water. You can use Vaseline, Puricim. Semi-permeable films or hydrocolloid dressings can be helpful. You can leave them in place for an extended period of time. And you can also, and I found these to be helpful. I started using those and they really do result in some improved healing over just by keeping it nice and clean and moist the whole time you're having it heal. And then you want to cover any area with road rash as it's healing with sunscreen because that will decrease the scarring. I wanted to include a little bit on mountain biking here. This is my new hobby from road biking, and it's a little bit different. The bike fit really depends on the discipline and style of riding. The more aggressive downhill, the lower people like their saddle. Again, as you can see, this person is almost behind their saddle, almost on their tire in position while they're going down this obstacle. They're moving around more. Standover height is still important. You don't want to have a perineal injury from sudden dismount. Newer mountain bikes often have a drop seat where you can actually drop the seat just to go downhill or just to go over an obstacle, and it comes back up pretty fast with just pushing on it with your finger. Pedals, platform pedals and with studs are common in the downhill and enduro disciplines, but cross country still a lot of times uses the clipless with the cleat. Injuries are really not well studied in this population. It'd be interesting to look at that, but we do know that acute injuries are pretty common. And also, mountain biking probably, not to say road cyclists don't have strength, but they require a little bit more core, lower extremity, upper extremity strength because they're moving around a lot more on the bike. For the same amount of distance, they're also using more calories because they're just moving all over in relation to the bike, whereas road biking is a little more static. Also, the bikes aren't as efficient. They have suspensions where you lose some of your energy as well. Ways to prevent injuries are to be more skilled on the mountain bike. Unfortunately, that takes learning, but sometimes focusing on these things, making sure you can dismount on different sides of your bike because you don't want to fall down a hill. If you're trying to get off quickly, you want to go up the hill, making sure you know how to brake, corner, which means turning more sharply. Wheelies and hops are important to get over an obstacle. Learning how to go down drops in the proper position and in a stable position. Jumping, probably a little bit more advanced. Picking the right line to go over an obstacle or through an obstacle. Pedaling efficiently is really important to get over some more complicated terrain. Climbing and switchbacks and falling properly is helpful. Concussion is also common in almost all sports. You can see it, pretty common in both road and mountain biking, although really not a lot of research in the cycling community compared to some other communities. It's very difficult to assess someone for a concussion in both a race and recreational environment. There might not be athletic trainers or doctors really readily available. Although most pro teams have a team doctor, they're usually not at the exact location that a wreck would occur, even in a professional road race. So a recent study demonstrated that cyclists actually have a high risk of prolonged symptoms. The mean duration was 23.7 months in the study, which is really long. And this came out within the past year. And it is noted that a lot of cyclists do have higher velocity injuries than some other sports, so that might be a reason for this, but this really hasn't been well studied. Also, sometimes when a cyclist comes in for more of a polytrauma or hit by a car, the concussion might be overlooked and not even identified because there's other injuries that are being treated, or the cyclist just gets up and keeps riding, which means that a lot of times it's not identified, at least at the time of the injury. And how would we evaluate concussion patients at a competition? We know we have the MADDOCS questions for sideline use for other sports, but asking someone what part of the game they're in or what team they played last week is not really going to help for cyclists. So some proposed questions from last year, an article from last year, which really haven't been well studied, is these are some questions we might be able to use for cyclists. Of what's the name of the race? How many kilometers are there still to go in today's stage? These are for professionals. Who is the captain for today? What was your last race? And what's your coach's name? So it would be interesting to study if these are useful with this population. And that also noted that these could be read by a team doctor via the radio for professional cycling, because they're not usually because the athletes could be spread out. They might not be at that location. No cyclist wants to wait for the car necessarily for their team doctor to catch up with them or come back to them to restart, which makes concussion management in professional cycling very complicated. Return to play after a concussion also has not been very well researched, but some proposed return to play would be starting with some light activity, at least when symptoms aren't worsening, kind of stationary trainer where where the athlete can't hurt themselves or fall off for 30 to 45 minutes at a heart rate of less than 70% max. Rollers are a stationary method of riding, but they do require balance, so you don't want to start with those. Those are basically like little rolling, like if you think of like rolling pins that you can just ride over in your house, but you can fall off. Then we can progress to non-group riding of low intensity, but you want to make sure it's in a more safe environment. Then non-group riding with bigger gears, hills, or intervals, and then going back to group riding with more intense parts of riding, including pace lines, which is riding close together with other people, climbs and sprints, and then going on to competition. So some take-home points: cycling provides many health benefits. It is a repetitive motion that puts stress on multiple body parts and is associated with overuse injuries. Acute injuries are also very common when crashes occur. And many overuse injuries are treated by both treatments that apply to other sports as well as thinking about their bike fit. And I'm on Twitter and Instagram at Caitlin Mooney MD if you want to follow me. And I wanted to have some time for questions because I know this is a topic not a lot of people have exposure to.
All right, awesome. Thank you so much. And we've already started to have some questions come in, so I'm going to go ahead and run through those. And actually, before you close down your PowerPoint, there was someone, Jessica was asking about the website that you had mentioned for the clavicle fractures.
Yeah. Let me.
And what I'll do is I'll send that link.
Sorry for my dogs. I took them for a walk this morning, but
the squirrels
are having. As soon as I turned this on, they decided there's something interesting outside.
Not a problem. That's the virtues of getting to do all of this.
Can you see that now?
Yes, indeed. Okay, social media, and I'm just gonna also put it into the question and answer area here, kind of as quickly as I can. Okay, and then send it off. All right, so, and then there's another question here from Kathleen. It's talking about, you can describe what the term float means on the pedal.
Yeah, I knew that was gonna be a hard thing. So float is so you're attached to the cleat and the pedal are attached at one spot. So if you think about, if you put your hands together, you can kind of wiggle them back and forth. So some pedals, you can move your heel about 10 to 15 degrees in any direction, but the ball of your foot is kind of attached to that pedal. But most pedal systems actually reduce your ability to kind of wiggle that heel back and forth by a set amount of degrees, and you can actually purchase ones that have X degree of float. A really popular brand of pedal a couple years ago was called Speed Plays, and those had almost free float. So you could turn, it was just a circle in kind of the circle went into the cleat, the circle cleat went into the pedal system, and you could pretty much go almost, probably not quite 180 degrees, but you could kind of really move your ankle back and forth. Some people really swear that having that free float makes you impenetrable to knee injuries, but there's also people who have pain because they can't kind of control that float and they actually have too much motion. So there are probably some people who really like having that motion because they're not in that fixed position, but you kind of have to be able to have the muscle strength to control being in the correct position to really use those pedal systems. I actually have seen a lot less of that sort of pedal system compared to probably the early, maybe 2000s, 2010s. But that's what I mean by float. So just the ability to move your ball, your heel in relation to the ball of the foot. There's really no system that's completely fixed. You don't want to have no movement, because that's going to put more stress on a lot of different structures, because then you're kind of, as you're coming down, your leg's going to be always in that same sagittal plane. But I hope that explains a little bit more.
Perfect. And Haley asks about, with tandem biking, starting to see that more and more often, what type of unique or specific injuries might you see with tandem as compared with the other types of biking?
That's interesting. I've never seen any book, anything about tandem cycling injuries, or I've never seen that really described. I would think they could be very similar sorts of injuries. Anyone on here tandem bike that has experience with that? I would have to look that up, quite honestly. I don't know.
Okay. Yeah, that's okay. Well, and I'm
not going to look up articles on tandem biking, because I never even thought about it.
And it seems like it's become more trendy. I'm not sure if there are competitive events involving tandem biking. So it might be something similar that you would see with a novice or social type of biker or cyclist.
That tends to be where I see tandem bikers. But I'm sure there's an event for almost anything these days. So I'm sure someone's doing that competitively.
All right. So those are the questions that I have here. What I am going to do is I tandem bike with my husband. Haley's responding. She says, I tandem bike with my husband, so I was wondering, as the rear rider, I can't see as well. So shock absorption, perhaps. And then she says that she sees various tandem bikes on trails and road.
More on trail? Or, sorry, I can't hear.
Yeah, she was saying as the rear rider, she can't see as well. So shock absorption was her speculation there. And then she has seen various tandem bikes on trails as well as on the road.
Mm-hmm. Yeah, I don't personally know anyone who religiously rides a tandem bike either. I do know some people who jokingly ridden like a 3 or 4-person bike, but I don't think they put enough miles on it to really hurt themselves.
And then Amber asks, I've seen clubs and groups that do visual impaired rides where the driver is seeing and the rider is either blind or reduced vision.
Yeah. Well, is that a question?
It was more of a comment.
Okay. Yeah, I know some people who've done that as well. And I don't know what that would be interesting if they communicate obstacles so that people know when they're going to get a little bit more of a impact, like the person said, with force dissipation and not knowing what's ahead of you.
I have not participated in one either. Okay, well, that is all of our questions. So thank you so much for your time and for presenting on this unique and interesting topic today. I want to thank everyone for coming. It was nice and early first thing in the morning, especially for those. We've got a lot of folks who tune in from California. So thank you guys for attending. Our next webinar is July 2nd at 7 p.m. And that's going to be an introduction to musculoskeletal sports ultrasound with Dan Clearfield coming from Fort Worth. All right. And any last things before we conclude today, Dr. Mooney?
I don't think I have anything left to say. I think cycling is an awesome sport. And I think it's awesome, great that so many people are joining it with the pandemic. I think the most important thing is always check to make sure everything on your bike is tight, because you don't want a wheel falling off. And really paying attention to maintenance is super helpful so you don't hurt yourself.
Awesome. Thank you.
Thank you.